So my name is John Garcia. I'm in the United States Air Force, and the topic that I chose for the technology talk is State of the Art Medical Simulation Center. The plan is enhancing medical training through advancements in technology. Just full disclosure, I have no relevant financial relationship to disclose relating to the content of these activities. You'll see some products may be highlighted, but I don't have any financial ties to those companies. The views expressed in this presentation are those of mine, and do not necessarily reflect the official policy or position of the Department of Defense or nor the United States government. So, introduction. One of the questions that I always ask myself is, what does it actually mean to have a state-of-the-art medical simulation center? Is it all just technology based? Is it just the high tech stuff, or is there more to it? What disruptive technologies that are employed at a state of the art medical simulation center, and what is the culture like? Because it always boils down to having a state of the art system is always positive culture based. So facility overview, just a very simple slide of showing, hey, a state of the art infrastructure is the technology in of itself, high fidelity mannequins, AR, VR, which we'll go through as we progress through the slides, and then a truly collaborative learning process from everybody within the team. I think it's important to have both. That way you can tap into the potential disruptive technologies to enhance the training in of itself, and then to have a very good system that applies how you appropriately debrief, how you give feedback, and then that's how people learn ultimately. Okay, so high fidelity simulators. High fidelity simulators are those that really present a patient or a patient-like status with some several complex injuries or complex capabilities. So high fidelity simulators, when I think about it in my brain, has the capability to be communicate with the individual who is in the simulator via the sim operator, who can have a pulse, breathe on their own, um, change pupils, if you will, and then just truly change or show physiological change for that particular patient that you want to portray. Right, so it can be wired or wireless operation. It really just depends on your budget and capabilities. The real time feedback, meaning that if your physician, paramedic, nurse, or anybody who's a part of the healthcare team say, hey, um, I just performed a needle decompression. Do their lung sounds actually change? Or we just gave this medication, or we just hang some blood. Do their pulse come back? Blood pressure change? So forth and so on. So that's when I think of a high fidelity simulator, that is kind of what I think of. Of course, it's not just a human high fidelity simulator, there's also canine high fidelity simulators. Um, so that's what I mean by the technologies that can be tapped into these systems. Virtual reality and augmented reality is the hot topic right now, I believe, within our field. Virtual reality and augmented reality, I believe these two things, of course, you can use VR headsets or augmented reality glasses. They provide a realistic 3D environments or simulations, right? So the benefits of it is spatial awareness and how you actually move, real time feedback because it's easier for that mannequin, because you don't need a mannequin, because that 3D rendering of that thing or your patient is actually going to give you that feedback. And then a safe environment for high risk scenarios that you can actually train. A couple of the things, we actually have a couple of VR headsets at my work, and a couple of the things that we found is that, you know, specifically for tactical combat casualty care or TCC, when you're up trying to apply pressure on a wound, it gives you this feedback of, hey, am I doing this pressure correctly, or how am I packing it? But because the controllers are not really simulating how your hands would actually work, it doesn't give you that realness or that feel that you're packing the wound or you're truly applying the tourniquet. So AR VR really has a place in helping you how to become a better decision maker, risk-free decision maker, if you tap into some sort of artificial intelligence that is progressive, that, well, really, if you give this medication, this is how the patient's gonna instantly respond, instead of an operator kind of manually changing the things, or an operator plugging in those parameters to a mannequin, right? So that's where the virtual and augmented reality would really kick in, is how you would proceed with a procedure or a conversation with the patient. So one of the things that we practice with AR VR is bedside manners, right? So we have a simulator in the Air Force where we can type responses on how to build patient rapport, and that is simulated with AI, and that AI can give you different levels of difficulties, or as we say at work, you can be with a totally cooperative patient who doesn't necessarily give you questions or issues, or you can go all the way up to a very difficult patient, or mother of patient, or father of patient, or relative of patient, that gives you all sorts of hardships and difficulties within that scenario. So I think right now, at this moment in time, that's where AR and VR kind of comes into play. Of course, the Da Vinci machine, which you can make a kind of training module and training scenarios. That is a different system than the actual AR VR that we know. Additionally, the virtual reality that it could put you in is really great for anatomical modeling. Because the way that it gives you in this immersed environment is that it puts you where you can actually see the vein, and you can pull it up, kind of almost reviewing a CAT scan or an MRI, that you can actually see those blood vessels pumping, or you can see the muscles retracting, or you can see the bone breaking. So again, that's all a part of the AR VR realm. There's a place to it, but when you're trying to teach a young medic, a young corpsman, um, how to truly apply pressure, I don't think VR or AR is there just yet. Mass casualty incident training. So a part of being in the military is mass casualty incident training. You need to have really realistic scenarios. So you need maybe some simulated patients or some standard patients to play those things, right? So simulations with multiple casualties, and then triage and resource management exercises. So a lot of people really play into the simulation where they say, yep, you were able to put on a tourniquet or pack that wound, or um, do dressing changes. What needs to be practiced, especially if we're going to go um, into a different environment, is resource management. Hey, how many does this patient actually need a tourniquet, or do they just need to have a pressure bandage? Do they actually need this, versus does my patient actually do this? So one of the things that we do practice, um, at least in our scenarios, and as you guys can see in this picture, this is actually the European African Military Nursing Exchange that just happened about a week ago, really last week. Is how do we manage those resources? And I think that's a part of mass casualty incident, and that's how we do really state of the art training, is that we put the individuals who are going to go out there in the field into the environment that they will be participating in preparation for the conflict or for the humanitarian exercises. A lot of people really, when I think of medical simulation, is when your fear of the unknown is going to be greater than the fear of the known, and when we expose them into these things, I think they are more comfortable, or at least the students are more comfortable in making those tactical level decisions or the operational decisions that they need to, in order for their patients to have a better outcome. So mass casualty incident training, the focus areas are is a rapid assessment and treatment. So typically we use SALT, um, coordination under stress, and really how you move logistically, and then the effective use of limited resources, which I had already mentioned. Next one is interdisciplinary training. I think this is important when a physician, a nurse, a technician, a paramedic goes into a room, goes into a scenario as a team built itself or trying to be built. It is a team based learning, so you need collaborative efforts among various healthcare professionals. Sometimes we even add pharmacists, dentists, biomedical engineering teams, bioenvironmental engineering teams, or public health, because all of those things really need to come into play when we do military operations or public health level of operations, because no one physician is going to enact everything and no one team member can do everything. So that collaborative effort, that interdisciplinary training is truly valuable. Another valuable part, before I forget, is actually nutritional medicine that I've been seeing recently. Simulated fiddle hospitals and evacuation scenario, that is critical, right? So if your vehicle readiness squadron or your the folks who do your vehicles, they don't show up to move your casualties, your hospital's going to get backed up. If the airplanes, the ships, the trains don't come when they need to evacuate the sick and the injured, unfortunately, your hospital system, your field hospital system is also going to get backed up. So those are very important key scenarios and key things to truly practice, right? So the things that we are looking for is how do you effectively communicate and how does the teamwork actually do, right? So leadership in crisis situations, and then interdisciplinary coordination. How does the physician, the technician, the nurse communicate with the ancillary services that's needed? Hey, I need that lab report. Well, the lab report can be processed because BMET, biomedical engineering technicians, are still working on the actual machine. Or, the sterilization equipment is actually down and it actually takes 4 hours for it to sterilize something. Well, the surgeon and the OR nurse and the OR tech needs to know those things. So those are very important to not just doing simulation in a state of the art facility. Time is also going to have to be a factor, and that also needs to be factored in because you cannot just fast forward time in real life, just like in some medical simulations. Data analytics and performance feedback. I think performance feedback is one of the most critical things that we need to do as simulation leaders. So, how do you provide a safe space for you to provide that feedback to your troops, to the students that you have? So, you must have a comprehensive performance tracking and feedback. So, what we have at my work is really a sheet where we write down chronologically from start to finish, and that's what we use to debrief based on the phases of medicine that they are in. So essentially, if you think about it, uh, in any real situation or in any real scenario, there's three phases of medicine, right? So point of injury care, en route care, and definitive care. So when you think about it like in a continuum like that, then that's how you can give performance or comprehensive feedback. So as a flight medic, we look at um, pre-brief, brief, mission execution, and then the debrief is how we kind of do this. So A, you need to do real-time monitoring and data collection, right? How well is this team actually performing, or how well does this individual actually performing their task? Are they actually doing chest compressions correctly at a rate of 100 to 200 beats per minute, or are they below the 100, or are they above the 120, right? Are they doing the accurate depth? So you need to give those feedbacks or metrics in accordance with your local policy and guidance. The benefits of it is to identify the strengths and the areas of improvements. These are students that we are trying to mold into becoming better professionals and better people who can deliver medicine in any type of scenario. So then we need to identify what they're already good at and develop what their gaps are. So tailored training program. You can train. It depends on the scenario, and that's what medicine is always at. It depends kind of question or answer to the questions, right? Because should you train a 20-year trauma surgeon with thousands of trauma patients the same way that you're going to train a brand new surgical resident? Probably not, right? The challenges would be very different or vastly different from those two. So you need to tailor your training and who is your audience and who are you trying to cater to, right? So you shouldn't at least train a paramedic the same as a trauma level surgeon individual. Lastly, is the continuous skills development. Skills can atrophy just like muscles. Skills can degrade over time if you don't practice it. So we, at least at our medical simulation center, we practice intubations every so often, IV starts every so often. It is to make sure that the skills that you have, the foundations that you have, is constantly there. And then how can we improve upon that skill, or what else can we think of that we're not doing to do those skills better, maybe faster, and quicker. So again, this is actually a nurse captain giving some feedback to one of our native countries over here in Utah. Case studies and success stories, so real world applications and examples of successful training outcomes. So, training, we really default on how our training is and how good our training is, right? So, an example of that is when we at aeromedical evacuation set up the aircraft and say, hey, the aircraft is really designed for cargo and we're trying to transform it into this flying hospital. So, oxygen lines and oil lines should not be mixed together. Oxygen lines and electrical lines should not be mixed together. So when you practice that by muscle memory over and over and over again, you will see the difference between a 6-month flyer and a 3-year flyer, where it's just instant to the 3-year flyer's brain on where the oxygen should go and how to kind of circumnavigate the situations depending on cargo versus a 6-month flyer, and it takes them a little bit. So those are successes of training outcomes that we need to be looking out for, and we need to document those successes in training outcomes because that way, it's a learned thing that hey, we train like this because of this, right? Testimonial from healthcare providers, when you put them in certain scenarios and they actually say, hey, I actually got better because the way that you guys trained me, right? So you can see that typically in Teachable C, when you from day of training 1 to day of training 8, which is the combat medic corpsman/corpsman course, and you can take how fast they can start an IV from day of training 1 and day of training 8. It's almost half of that time. And the reason why is because they're now low crawling and they now know more techniques that work for that individual and to better apply that. The impact is, of course, improved readiness and response times, and then the enhanced patient outcomes. Future developments. So, what do we do in order to actually make ourselves better? So, we do ongoing research and innovation, and that's where Teachable comes in. Upcoming technological advancements. Here in UCOM, we really look at at least in the Air Force, the Innovation Center to say, hey, what kind of innovations have you guys come across? And let's have a chat about it. And then we put our thinking caps on and we think, hey, how can we actually use this in simulation, right? One of them, as of recent, is making ballistics gel and then putting silicone tubes inside of that ballistics gel and just shooting it, where you can actually see the injury pattern into that ballistics gel and say, hey, when you present that to your students, hey, this is why wound packing really works. It's because a ballistic gel mimics that, right? So if you just use the formulation that the Federal Bureau of Investigation puts out there, you can make your own ballistics gel and it's fairly easy. Continuous improvements in training methodologies. The adult learning method has kind of been propagated throughout the system, but is that, we always question, is that really the best way that students learn? And then our typical goals when our future development is how do we keep pace with evolving medical needs, ensuring that the highest standards of medical care is applied, and our clinical nurse specialist actually does the evidence-based practice to make sure that what we do and what we put out in our medical simulation is the current evidence-based practice of it. So conclusion, last slide, mandatory picture slide of all, is the facilities, right? So you have, again, you have a technology side where it's really cool, high fidelity mannequins, but that's not all, right? You need to develop a culture of learning, and that's what really, those in combination and almost in synchrony, makes a state of the art medical simulation center there. And then the importance of not just advancing technologies, but also advancing how you guys debrief, pre-brief, and how you teach your students. And then lastly, the commitment to excellence in medical training. If you guys have any questions, unfortunately, I'm not going to put my information for YouTube, but please let me know if you guys have any questions or anything like that. This is just a picture of some TCCC training that we're doing here in the Ryland Falls area. Thank you.